This conference will now be recorded.
Assalamu alaikum wa rahmatullahi wa barakatuh. In the name of Allah, we'll start the fifth session revision for MRCOG part 2, who are preparing for the exam in September, inshallah. Today, we'll start to discuss important points regarding urogynecology. When you started to prepare for part 2, urogynecology is very important module. But the problem we don't like this module because it's not our daily life, but we wanted to know the basic points in this module so you can answer any question you can face in the exam. Even when you are preparing for part 3, this is very important how you can read urodynamic studies, because in the exam, this could be the first question if the examiner give you the study and ask you what is the diagnosis of the patient. I will start to talk about urinary incontinence because most of the question will be about urinary incontinence, either stress or urgency. And the management is very important, especially the NICE guideline. You should know what is the step, first step, second step, third step, when you are going to refer the patient for secondary care. We will talk first about that urinary incontinence. This is affect up to 70% of the female population. At a certain point in her life, she will complaining of incontinence. The most common types: stress, urgency. Sometimes the patient can have both. So from the history, you can detect this patient what type. So if she is coughing, she tell you, doctor, I have leak with cough. So this is stress incontinence. So from the history, you can check what is the main complaint of the patient. Stress incontinence, patient when she sneezes, with exercise, coughing, she will leak. So from the history, you can tell that this is a case of stress incontinence. Urgency, the patient, she will tell just, I will rush to the bathroom and I wanted to pass urine suddenly. Usually the patient with urgency, before the bladder fill, anyone will have bladder full bladder, he will go to bathroom. But this patient urgency, just little amount of urine, she wanted to rush to the bathroom, and this is sometimes affecting her life much. I think the voice is clear. Voice is clear, correct? Can you please write if voice is clear, because some clear the voice? Okay. So this can affect much the patient life, especially if she is working. This can affect even her social habit. If she wanted to attend any party, she can't. This is in total can affect the patient life because she will need to go bathroom frequent time. Sometimes in the exam, he give you a scenario about one patient with continuous leak. There is several causes of continuous leak, but sometimes it can be like patient post-delivery, obstructed labor, one patient post forceps. Usually the case will be a case of fistula, but there is other cause also of continuous leak, like patient with urine retention with overflow. Patient, she has retention, and when the bladder become full, patient will start to leak. So this can be fistula, this can be urine retention with overflow. Assessment will start when the patient come to you to the clinic, because you will be the one to see the patient. What is her complaint? Why she come to the clinic today? And assessment by history is very important and very vital, because this is also you will decide which treatment will be suitable for the patient. Even when the patient enter to the clinic, when she entered to the clinic, just before taking history from this patient, you can expect that this patient, she has incontinence also, like patient with abnormal gait, like patient with paraplegia. So you can expect that this patient also, she has a urinary incontinence. Important points in the history when you assess patient with incontinence, to ask her regarding the incontinence, presenting history. When she started to have this incontinence is continuous, because we tell could be like differential diagnosis fistula. This one interrupted, she need to rush to the bathroom. As she is wetting herself before going to the bathroom, because some patients, she can tell you, doctor, I rush to the bathroom, but still I can control myself and I will pass urine there, I will not wet myself. Other patients, she will tell you, no doctor, I wet myself before I reach to the bathroom. If she has leak with cough or sneezing or exercise, frequency, how much time per day she is passing urine, how much per night. So at least should be at night 1 time, it's normal, but more than 1 times per night also it's not normal. If there is any pain, because this could be urinary tract infection, any change in the color of the urine, this is very important, especially if the patient, she tell you, I have hematuria. Hematuria, frank hematuria less than 50 years, this could be a cancer. Microscopic hematuria more than 50 years, this is also suspect that this patient, she has cancer bladder. So frank hematuria, this is very important to ask any change in the color of the urine, because this can give us key what could be the diagnosis. If the patient, she has mass, like she has fibroid or ovarian tumor, this is also can cause pressure, can cause frequency. So this is important question. If she asks you, doctor, so if she has like detrusor overactivity and she has big fibroid, she tell you, okay, doctor, so if you remove the fibroid, this will improve the urgency. No, the removal of the pressure, this will decrease the frequency. But if the patient, she has problem already in her bladder, like detrusor overactivity, this will not improve her condition. Be careful from this point, because this is asked in OSCE exam before. Patient ask, if you remove the fibroid, this will improve if the urgency. No, this will improve only the frequency. If this patient, she has vaginal prolapse, and we can put here if she has leak with sexual intercourse. In general, this is affect her life or no. Sometimes she can tell you, I'm wearing a sanitary towel, so I can go to work. Age of the patient also is very important, because when the patient older age, this will increase the risk for her to have incontinence. Gynecology, she is last menstrual period, this patient to menopause or no. Obstetric history is very important. We need to ask her how many times she delivered before, mode of delivery. If there is any instrument delivery, forceps, ventouse, how much the weight of the baby, any complication developed for her after delivery. And if the patient, she has a problem in her urine, especially after delivery, it's important also to ask if this patient received spinal or epidural. Fetal weight, especially if the fetal weight, large fetal weight, this will increase the weakness, the risk of weakness of the pelvic floor muscle. If she has medical disease, especially neurological disease, bronchial asthma, patient is coughing, maybe not controlled, this is also could be a predisposing factors for this patient to have incontinence. Diabetes, if not controlled also, this is also a predisposing factors for this patient to have incontinence. Any surgery before, maybe this patient, she has adhesion, maybe this patient later maybe need operation, so we are expecting that there will be adhesion inside. If she is using certain drugs, increase the problem for her, like diuretics. If she is taking specific drugs, any drugs like HRT for post-menopause, postmenopausal symptoms. Other history like cervical smear, social habit is very vital. Social habit, she's a smoker, because this can increase the problem for her. She is drinking alcohol. She is taking much caffeine. This is also increase the problem to her. And her occupational also, especially if she is lifting heavy things, this is also will increase the problem and increase the urinary incontinence for the patient. Family history of similar condition also is important.
Ma'am, I need to ask you one question here, please.
We can postpone the questions to the end, if possible, okay? Just write it down and I will open discussion in the end. Okay, doctor,
Okay,
what is your name?
sure.
What is your name,
I'm
doctor?
Nikita. Nikita.
Okay, Dr. Nikita.
Okay.
So the examination of the patient, this will be very important, like vitals, body mass index, body mass index. Why? Because this patient, she could be obese. So decreasing her weight also can help for her to improve her condition. Abdominal examination, if there is any distension, any tenderness, any fibro, if you can feel any mass inside like fibroid. Vaginal examination, if there is any leak, especially if we are asking the patient to cough, she can leak during the examination. If there is continuous leak, also we can observe. Investigation, be careful. First step, we need to exclude that this patient, she has infection. This is important. Is this patient, she has infection or no? After this bladder diary, if given in the exam, this patient, you did for her already bladder diary or no? The patient, she will write in the bladder diary, we will discuss this point later, 3 days, all the amount of fluids she is drinking, how much urine she is passing, and we will see the bladder diary. So the first investigation exclude this patient, she has infection, then bladder diary. Some thinking in the exam, because you are taking exam for MRCOG, so you should do the expensive investigation for the patient. So this patient, she has incontinence, you could leave the urine screen for urine infection and you can choose urodynamics. No, you should go step by step. So the first step, I need to exclude infection. Second step will be bladder diary, and we'll discuss more regarding the bladder diary. After this patient, we will see this patient, what is her problem. According to her problem, we will start the treatment. So this is stress incontinence, this is urgency. So we need to, what is the patient complaint? So we will start the treatment for her. I will start with urodynamics study, because in the exam, in part 2, or even if you are preparing for part 3, the examiner can give you a study, a urodynamic study, and he will ask you, what is this? And even in part 2, he can give you a urodynamic study in the exam, and he will ask you, what is your diagnosis? So this can be a question. And don't think that no problem, even this question will come in the exam, it will be difficult for me, I will leave. Okay, but you could need only 1 mark to pass, only 1 mark. And if you see several candidates in last exam just fail just 1%, maybe 2 marks. So maybe 1 mark will help you to pass the exam. So in urodynamics, they will assess the bladder and urethra, how they are performing their job to store the urine and releasing urine. So we have cystometry, uroflowmetry, others advanced, but usually it will not appear in the exam, to check if the bladder and urethra performing their job in storing and releasing the urine. How they will do? We need to, when you are doing, what is the indication? You will not do for any patient. No, you should have certain indication. Like this patient for stress incontinence, if the patient, she tell you, doctor, I have incontinence when I cough, when with exercise. So this patient, no need for urodynamics. Already you can diagnose without urodynamics. Patient, she tell you, I will leak, doctor, when I'm coughing. So this is pure stress incontinence. But if the patient, you treat her and do surgery for her for stress incontinence, and still the patient, she complaining, so at this point you can do for her urodynamic study. So one of the indication, if the patient, she has history of previous surgery for stress incontinence and still she is complaining. If the patient, she has anterior prolapse, if the patient she has apical prolapse, if the patient she has symptoms of voiding dysfunction, if the patient she has urge predominant mixed incontinence. Urge is, we have mixed incontinence. In mixed incontinence, mainly you need to ask the patient a very important question: which symptoms affecting her more? So she will tell you the urgency more. So if the urgency is a predominant mixed urinary incontinence, so it's also indication for urodynamics. If the patient she has also urinary incontinence and the type is not clear, this is also indication for urodynamic study. How they will do? In the start, they will insert a catheter, Foley's catheter, and they will check how much residual urine. How much residual urine? It should be less than 50 milli, and it should be recorded. So now I insert the catheter for the woman. How much residual volume I should record? Then I put two transducer, one inside the bladder. It will record the pressure inside the bladder. This is the physical pressure. And the other transducer will be in the rectum. And this is where record the intra-abdominal pressure. This is what you are seeing in the, I will show you in the next. I just explain for you how this, you are seeing only the study, but you don't know how they will do. Just to know how they are do again, catheter insertion, residual volume, the urine remaining in the bladder, they want to see how much. They will record. There is two transducer, one inside the bladder. This is will record the intraphysical pressure. Another one will be intra-abdominal. This is will record the intra-abdominal pressure. How they are recording is the trousers pressure. The trousers pressure will be per physical pressure minus per abdominal pressure. This is will give us the trousers muscle pressure. Then they will start to fill the bladder of the patient by 100 milli normal saline, and the patient sitting in the commode like in the picture, and the patient will tell us, she will talk, she will tell now this is the first, I can feel my bladder filling sensation. So she is feeling there is urine in her bladder. This will be the first sensation. So she will tell now, I inject how much. So if the patient 150 and she started to feel, this will be normal. So the patient will tell you. So she will tell you, I will write here, this will be the first sensation. At certain point, the patient, she will tell you, no, doctor, I can't withstand. I want to void now. This will be the strong void. It should be from 400 to 600. This is the normal. This is all will be recorded, and after this, you need to know what is the normal, so you can tell this is normal and what is abnormal and what is your diagnosis. Because in the exam, he will give you the study, and you need just by your eyes, you will tell this is a case of urodynamic stress incontinence. This case, the trouser overactivity. So just by your eyes, just one look, you can diagnose the study. There is some precaution, like you can tell the patient to stop any medication. Sometimes you can be taking medication for incontinence. So you tell her at least 5 days before the test. And if there is any predisposing factors, should be also treated like constipation, because this can affect the result. Okay, so now I'm in the exam. I don't have any idea regarding urodynamics at all. First, I bring all the urodynamic chart studies here from Google. It's not belonging to me. I just bring it to make it easy for you. So all rights reserved, because I just search in Google about some how it will be appear, because we are not working in urodynamics. Just all the charts in the PDF, I just bring from Google. The first thing, I am now in the exam. I wanted to know how I will read. Concentrate well, because some of you will share now, because I prepare some, so you can share how you are going to read. So concentrate well. Here I will see this is the per physical pressure. I just until I put one transducer inside the bladder, I will check the physical pressure. This is the bladder pressure. Another transducer will be in the rectum. So this will be the per abdominal pressure. The other one, we tell just now, per physical minus per abdominal, this will be the trouser pressure. It's easy. What is the first point in the exam I will look? You will look to the detrusor pressure. Why? Because from the detrusor pressure, you can exclude that this is a case of detrusor overactivity. Where I will look for the first, I will look for detrusor pressure. This is the line. This is called filling phase. Filling phase mean what? I'm injecting 100 milli saline per minute. I am injecting. So this is the filling phase. Here, the patient, she tell me, I can't withstand. I want to pass urine. So this is called voiding phase. So concentrate well. You are reading filling phase or voiding phase. So when you start to look, this is the pressure. So this will be the filling phase. And in the end will be the voiding phase. Sometimes it can be by reverse. They can put here the periphysical per abdominal, it can be here, and they will start the filling phase here, no problem. It can be right or left, no problem. But usually in the exam, it will be in this side. So I will look here, this is the filling phase. Should be careful, should be during the filling phase, no contraction, like uterine contraction. If you see this patient no contraction in the detrusor pressure, this is not a case of detrusor overactivity. Finish. We finish this point. It's normal. Normally, should be the patient don't have any contraction during the detrusor, during filling phase. I think the voice is clear. Please, if voice not clear, just okay. Maybe you have internet problem, doctor. Just check if there is. You can leave the meeting and join. Okay, leave the meeting and join. Okay. So again, you will look to the detrusor pressure. If there is contraction, how much is the contraction? It will be abnormal. If frequent, 5 centimeter water, this is abnormal, frequent. And if you have 15 centimeter water, this patient has a case of detrusor overactivity. So I will look the detrusor pressure, no pressure, no any contraction. So this is not case of detrusor overactivity. The next point important in detrusor overactivity, this patient first sensation where? If first sensation 150 or above, this is normal. So if you look here, this is the first sensation. So could be the first sensation here or up. So in the exam, you can see the first sensation here, no problem. So just look where is the first sensation. So 170 milli, this is normal. Okay, but if this one less than 150, like he gave you in the exam, this is 132. So this patient, she is a case also of the detrusor overactivity because the first filling is less than 150. Easy. So again, I will look to the detrusor. If there is no contraction during the filling phase, this is normal. This is patient normal. I will look to the first sensation more than 150, so this is normal. But if he give me this patient to start to first sensation less than 150, like 130, 120, so this patient will not waste time. Please try to mute yourself all. Hello? So not waste time in. Okay. So I will look to the first sensation. What is the normal? The normal more than 150. 150. Okay. I learn now. Before I mute myself, I will not talk. Now I learn. So I mute myself. The first, the capacity of the bladder, how much should be from 400 to 600? So it's normal. So now I wanted to know the normal. The normal first sensation 150 or more. Normal. A bladder capacity from 400. This will be the end. The patient, she will tell you, I want to void now. So it will be from 400, the maximum capacity will be 600. So this is normal. If he give you first sensation less than 150, so this patient, she has the trouser overactivity. If he give you the bladder capacity less than 400, like 350, 380, so this is a case of also trouser overactivity. I will look, this patient, she has leak. For example, I look to, okay, I rather tell me I will look to trouser pressure, there is contraction. So there is contraction during the filling phase. So this patient, she have the trouser overactivity. One only more than 15 centimeter water, or frequent more than 5 centimeter water, this means that this patient, she has contraction. I will look, this patient, she has leak with the contraction of the trouser pressure. So this patient, she has wet the trouser overactivity. What mean? The patient, she will tell, doctor, I have urgency. I need to rush to the bathroom every 30 minutes. But when before I reach to the bathroom, I wet myself. So this patient, she has the trouser overactivity wet time because she is wetting herself. Another patient, she will tell you, doctor, no, I need to rush to the bathroom every 30 minutes to pass urine, but I can control myself. I can reach to the bathroom. This will be a dry time. So the patient will not wet herself. This is the first point. Second point, I will look during the test. We will ask the patient to cough. We will tell her cough. Any leak? Because this is we're recording if there is any leak. If any one of us, if we are coughing, should be no any leak, because this is normal. Anyone will cough, will sneeze, should be no any leak. But if the patient, she has leak during the test with the cough, the physical pressure will increase, like here. The abdominal pressure will be increased, and there is no leak. If you look to the flow, nothing. This is normal. One patient coughing, abdominal pressure increase, the trouser pressure increase, and normally there is no leak. So this is normal test. But if he give you in the exam, the patient is coughing, and the abdominal pressure increase, and the physical pressure increase, and there is here flow, and he put leak here. So this patient, she is a case of urodynamic stress incontinence. This is the easiest way to read the urodynamic study.
Please repeat this point, ma'am.
I will repeat again. Don't worry. We will not leave today until you know how to read urodynamics. The first sensation should be, you should know the normal. The first sensation, I will look to in the exam. Here, 170. Gada tell me it should be 150 or more. So it's normal. If it is 130, so no, it should be 150. So this patient, she has the trouser overactivity. I will look to the end, how much the bladder capacity. So it's 500. 500, we tell it should be from 400 to 600 the maximum. So it's normal. If he put in the exam, this patient 300. So this patient trouser overactivity. She can't do, the normal should be 400. The bladder of the patient should at least 400 to 600. So after this, she can tell, I can't withstand, I want to pass urine. But patient can't withstand, and at 300, this means that this patient, she has the trouser overactivity. If the patient in the exam, don't be surprised if they don't put for you the first sensation or bladder capacity. If you see one graph, sometimes the graph will be not clear. Where is, you are surprising, where is the first sensation? Nothing. Where is the bladder capacity? Nothing. Just look to the trouser muscle pressure. If there is contraction, it will be very clear. This is a case of no need for anything more. You get the idea. Even he will not put for you first sensation and the bladder capacity. He put you the trouser contraction during the filling phase, and we tell the normal should be no any contraction during the filling phase. So what about this? Oh, the trouser pressure here. Oh, it's reached to 54. So this is normal or abnormal? patient here, she is voiding. So this is normal or abnormal? This is normal because the patient, she is urinate. Now she finished the test. She tell, I wanted to urinate. So you can pass urine. When she pass urine, the trouser contraction normally will increase because the patient evacuate her bladder. So the trouser contraction during the voiding phase is normal. So I'm looking here. So if all increasing, no problem, because the patient, she is urinate. There is leak. Yes, there is leak because the patient, she is urinate, because we are reading the voiding phase here. So you should confirm what you are going to read. This is the voiding phase, and this is the filling phase, and this is the voiding phase. Again, no contraction in the detrusal muscle during the filling phase. It's normal when the patient, she is voiding to have contraction in the detrusal muscle. You will look if there is any leak when the patient coughing. How I will know the patient cough? The abdominal pressure will increase and the physical pressure will increase. I will look down if there is any flow. So this patient, she is a case of stress, urinary urodynamic stress incontinence. We will practice how to read again by different chart. So now I will look to the first voiding, bladder capacity in the end. There is leak during the filling phase. Leak during voiding normal. Again, be careful. When patient urinate, this is not leak because she is urinate by herself. So in voiding phase, leak is normal. Abdominal pressure were raised. Physical pressure were raised. The detrusal pressure is raised or no during the filling phase. We will practice now. We will take different candidates for the urodynamic study just to reassure you are understand the study. So we will take several candidates for each study. Okay, who can chair the first one?
I'll volunteer, Ankita.
Okay, we will take the urodynamics. Each one will take one to confirm that all understand the points. Okay.
Okay, ma'am.
You can see this one.
Yes, ma'am.
Okay.
Patient complaining of urinary symptoms. Should I read, ma'am?
Yes, read. Yes, read.
Patient complaining of urinary symptoms, including incontinence. This is a urodynamic study is available. So yes, the first sensation to void is not given, and the bladder capacity is also not given. Vesical pressure is increasing,
I
and
will not be
abdominal
surprised
pressure is increasing.
if they will not give me the
Pressure is
first
normal.
voiding. Okay.
Yes, ma'am. Ma'am, answer should be stress incontinence, urodynamic stress incontinence.
Why not choose C?
Yes, ma'am. C can be the option. But because there is no clinical, like there is no coughing or something. There is no stimulus is given, ma'am. Coughing, something like that.
She is coughing. No, she is coughing.
No, because
She is coughing. If the patient come to your clinic and she tell you, doctor, when I'm coughing, I will have urinary leak. This will be stress incontinence. Because this is clinical diagnosis. I diagnose the patient clinically. She tell me I am coughing. When I'm coughing, there will be urine leak. So this is clinical diagnosis. But if you confirm this one by urodynamic study, this will be urodynamic stress incontinence. So be careful in the exam. If he put urodynamics chart for stress incontinence, don't choose stress incontinence because this will be a clinical diagnosis. I diagnose the patient without any investigation. But once I confirm that this is a case of urinary incontinence, stress incontinence by urodynamics, this will be urodynamics stress incontinence. Be careful. In the exam, you will answer this question wrong and your mark will decrease. Remember this. So tell me how you diagnose
okay, ma'am.
a
Yes,
case
ma'am.
of stress.
Hello.
Yes, how you diagnose?
Hello.
Ma'am,
Let her finish.
Ma'am, because whenever abdominal.
Yes. Tell
Yes,
me
ma'am.
how you
Because
diagnose.
whenever abdominal pressure is increasing, yes, ma'am. Because whenever the abdominal pressure is increasing, vesical pressure is increasing, and there is a leak.
So if Dr. Ankita, if there is no leak here, what will be your diagnosis?
It will be a normal study, ma'am.
Excellent. It will be normal. Patient coughing and no leak. Will be normal. And no leak. Abdominal pressure will increase, vesical pressure will increase, and there is no leak. But if there is leak, so during the
Yes, ma'am.
filling phase, this patient will have urodynamics stress incontinence. Thank you, Dr. Ankita. Still, we can take
Thank
another
you,
one.
ma'am.
Ma'am, can I ask a question?
We can postpone the questions until the end. Just anyone have any question to not decrease the concentration of others. Just write it down.
Okay.
I will open discussion in the end of the session. Okay, but you can share this one, Dr. Bahwan. What is your name?
Is this leak related to the cough or is it related as the voiding phase?
This is during the filling phase. The voiding phase will not all this duration. This is very long. This is voiding phase. Okay.
Okay, thank you.
Who can share the next one? Just we need to confirm that all of you understand how to
Ma'am,
read.
I want to try.
Dr. Nikita,
Yes,
what is your name, doctor?
I'm Dr.
Okay.
Nikita.
Okay, read the question.
Patient complaining of urinary symptoms, including incontinence. This is her urodynamic study that is available. So, vesicular pressure, abdominal pressure, but detrusor during the filling phase, there is detrusor overactivity. And also there is leak at the same time. So it is detrusor overactivity. Answer is B.
Answer is B. So why you choose B?
Because in the clinical, when she comes to the OPD and she tells that she's having urgency, then it means like without urodynamic studies we call it overactive bladder. And if
So
we
this
have
is the clinical.
confirmed,
Yes, this is clinical
that-
diagnosis. When the patient she tell you
yes.
I have to go to the bathroom, so my diagnosis will be overactive bladder. So when I
And when I
confirm by
confirm, yes, when I confirm with
what-
urodynamic studies, then it is detrusor overactivity, like stress
How you
incontinence and urodynamic stress incontinence.
how you diagnose that this is a case of detrusor overactivity? Why?
Because during the filling phase, the vesicular pressure and abdominal pressure are normal, but during the filling phase, there is increase in the detrusor pressure, and at the same time, there is also leak in the urine.
So how
And
much?
down arrow, they have given that it is filling phase. So in the filling
So
phase, there should not be any detrusor activity in the filling phase.
So how much should be will be contraction? How much the pressure should be there? So I will tell that this is contraction.
More than 15 centimeters of water.
One contraction more than 15 centimeter water, or frequent contraction more than 5 centimeter
More than
water?
5 centimeter.
Frequent.
Yes.
If frequent, one only, so more than 15 centimeter water. If frequent small, more than 5 centimeter water, so this is also the detrusor overactivity. So doctor, again, I will ask you a question. If there is no leak here, what is your diagnosis?
Then we will not call it incontinence.
Not incontinence, but what is the diagnosis? Patient, she tell you, I am rushed to the bathroom, doctor. Every sentiment, I go to the bathroom. I can't control. I wanted to go bathroom frequent times. So what will be the diagnosis?
So probably it is some cystitis. You know, interstitial, some cystitis, because of which there is.
No.
Right.
We exclude infection. We treat all the infection before we are doing the study.
Okay, yes, it is called, yes, it is called dry detrusor overactivity. There is wet and dry, two types of overactive bladder.
Excellent. So will be the dry type. If the patient will not leak before she reaches to the bathroom, will be trouser overactivity, because just now you tell should be no contraction. So if there is contraction, this is the trouser overactivity. So either this patient wetting herself before reach to the bathroom, or she can hold herself and she can pass your urine there in the bathroom.
Yes. And ma'am, you said frequency more than 5 centimeter water. Is there any number for that frequency? How much frequent
no,
the contraction?
More than one. Only
more
one.
Than one. Okay.
More than
more
one.
Than
So
50.
Oh yes.
Okay.
Yes.
Right. If it is only one,
yes.
if it is only 1 5 centimeter of water, then it is not considered.
Yes, only 5 centimeter water. No, only one contraction should be more than 15 centimeter water, or frequent contraction more than 5 centimeter water. Clear?
Okay. So one contraction less than 15 not considered.
Yes.
Right.
Don't worry. Anyone finds this is for me, for urodynamics for the first time, it was really very difficult. I hate to read even urodynamics. But really, there is one excellent professor. He's working in famous university. I attended only one session with him. I really like urodynamics because he is not a OB-GYN doctor. He was a urogynecologist, urologist. But he really simplifies the things, and just you need to know the basics. You are not a urology doctor, but you need to know the basics. So don't be confused. I am just every one from this can appear in the exam. If there is the trouser pressure increasing during the filling phase, this is not normal. This will be the trouser overactivity. If the patient come to the clinic still, I don't know, will be overactive bladder. This is just a symptom. So my clinical diagnosis. But if I confirm to trouser overactivity, what happened in the exam? In the exam, you are confused. You don't have rules. Just I know this is urgency, so I will use overactive bladder. He gave you urodynamic already study done. So why you are choosing a clinical diagnosis? Already confirm it. So if confirmed, so you will choose the trouser because you see already the trouser pressure increase. So you will choose the trouser overactivity. Who can share the next? Who can share the next? Don't worry. Don't worry. Anyone can share, even you tell something wrong. No problem. No problem.
I can share, Dr. Ghada.
Okay, Dr. Rana.
Okay, patient complaining of urinary symptoms, including incontinence. This is her urodynamic study. Okay, here's the first line. The first line is pressure, vesical pressure, and the second one abdominal.
Exam. We can put the pressure here or the pressure here. Usually it can be here, but no problem. If they start from the right or the left, no problem. But just you see the pressure, so this will be the start of the filling phase.
Okay, here there is. I will look first to the pressure or the trouser pressure. Here there is increasing in the filling phase.
And I will look. You see, I like. You know what I like? I like that you now have rules. I will look first to the trouser pressure. Excellent. This is the trouser pressure.
Okay, and here's the leakage. There is no leakage.
There is no leakage.
Yeah, and there is increase in the vesical pressure with the trouser pressure, but no increase in the abdominal pressure.
Okay, excellent. No increase in the abdominal pressure. Okay, so what is your diagnosis?
Here it will be the trouser overactivity.
The trouser overactivity. Because once I see contraction in the filling phase, this should not be normal, and could be why no leak? Why no leak, Dr. Rana?
Yeah, this is here the dry type. The dry type.
Excellent. Excellent. If you have rules in the exam, you follow the rules. Sometimes you can face first voiding bladder capacity in the exam. What is this? Nothing is there. No first void. What is this? No bladder capacity. But he put there clearly the trouser contraction frequent time. So why you are looking for others? Others not there. So he wanted to tell you that this is a scenario of the trouser overactivity. So this will be the answer B. Again, we are not choosing A because A, this is clinical diagnose. But now I confirm by study. Again, difference between A and B. Concentrate well. I am now in the clinic for the first time. I see the patient. She come inside the clinic. She tell me, doctor, I need to rush to the bathroom every 30 minutes. Every 30 minutes, either she will wet herself or without wetting herself. She tell I'm rushing every. So my diagnosis is overactive bladder. I clinically diagnose this patient. So I tell her after this, after initial investigation and conservative management, later I decide to do urodynamic study for this patient. This is the study come to me. I look, I confirm my clinical diagnosis, which was A. This is my clinical diagnosis, overactive bladder. Now I have evidence. I have evidence that this is a case of confirmation. So this will be the trouser overactivity. So I will choose the trouser overactivity when he give me the chart. Another patient, she tell you, doctor, when I am coughing, I have leak. I leak my urine. So this will be my clinical diagnosis. This is a case of stress incontinence. Later on, I do urodynamic study and she brings a chart. I look, I confirm. So this will be urodynamic stress incontinence. Clear? Easy. It's easy. Easy or not easy? Not easy. What happened? Easy?
Easy, Dr. Ghada.
Easy.
Yeah, very easy.
Become easy.
If you need to repeat, no problem. But don't worry, it's easy if you repeat again. For the first time when I hear the lecture, it looks difficult, but with the repetition, it's easy. This is one of the easiest module from all the exam, either for part 2 or part 3. Okay, we will take another one. I think there is another one. Another one, can it share? Another one?
I will share.
Dr. Adila. Okay, Dr. Adila. I just cut it because I search, but I just cut some from Google and I prepare it like this. Okay, you can read.
Patient complaining of urinary symptom, including incontinence. This urodynamic study is available. Okay. Here she has, we looked at the trouser pressure. There is increase in the trouser pressure. And also in the vesical pressure, there is an abdominal pressure. There is increase in the vesical pressure, and there is leak with cough. Is this leak on the vesical pressure, or just increase with cough? Okay, no leak.
It's written leak. It's written leak. Here leak and here leak.
Oh, okay. I think this is mixed incontinence because she has leak with over.
Excellent.
Yeah.
It's excellent. She can tell you, doctor, when I'm coughing, I have leak. Also, I need to rush to the bathroom every 30 minutes. So she have the two complaints. This is mixed type. So if you look here, patient, we tell before, during the filling phase. Why you tell this is mixed type? Explain, Dr. Adil.
Because she has increase in the trouser overactivity with leak, and then she has a vesical pressure increase with leak as well. So she has both mixed incontinence.
Oh, okay. So I will cut, Dr. Adila, keep. I will make this one disappear. And this is the only urodynamic study. What is your diagnosis?
It's still mixed.
No, I remove this point. I remove this part. This part okay. I remove from the group. Okay, just I wanted to test if you understand the other.
Okay, it will be wet the trouser overactivity.
Excellent. Wet the trouser. She didn't tell this is overactive bladder because this is already diagnosed. So this is wet the trouser overactivity. So Dr. Adila, if I cut this study from here and I give you only this study, there is this part not there. So what would be your diagnosis?
Will be urodynamic stress incontinence.
Excellent. she didn't tell stress incontinence because already I see.
Yeah.
If I suspect something, like I suspect one patient pregnant, this is, I suspect she is pregnant, but still I'm not confirmed. But when she brings the laboratory, I confirm. It's the same idea. So now I confirm by my eyes. So this is urodynamic stress incontinence. This is mixed type. Thank you, Dr. Adila. We can take another one just to confirm. Frequent candidates, they understand how to read mixed incontinence. Another volunteer. Don't worry.
I can do it.
Okay. Okay. What is your name? What is your name?
Shazia.
Okay, Dr. Shazia. Okay. Okay.
Patient complaining of urinary symptoms post-forceps delivery, including continuous urinary incontinence, no increase in detrusor pressure during feeding phase, post-voiding residual volume is normal. A, overactive bladder, B, detrusor overactivity, C, fistula. I think it is fistula because continuous urinary incontinence with the history of the forceps delivery. So it is like
excellent. There is some keywords. Patient post-delivery, maybe obstructed labor, forceps. Patient no detrusor pressure increase during the feeding phase and the post-voiding residual volume normal. So this is a case of fistula. So, Dr. Shazia, if they are putting the same question and they put that the residual volume, post-residual volume high, maybe
post-residual volume high, and then she has the continuous any incontinence with the residual volume high. You said like that? Hello? Yes, Dr. Ghada, can you hear me? Hello? Hello, Dr. Ghada? Hello, Dr. Ghada, can you hear me? Hello, Dr. Ghada? Hello? Dr. Ghada, I cannot hear you. Yes, can you hear me? Hello?
Yes, I'm sorry for this because electricity cut it. Sorry. I will try to connect by another internet until we solve. Just a minute.
Okay.
So, what is your diagnosis if the post-voiding residual volume high?
A post-residual volume high and install.
Ma'am, it's the atonic bladder, ma'am.
What?
Yes, atonic.
Atonic bladder, ma'am.
Continuous leak. Atonic bladder when the patient is voiding. What continuous leak?
Oh.
Overflow in incontinence. Overflow.
It can be over retention. It can be differential diagnosis, but mostly it can be over bladder retention with overflow. Just because I have problem now, I need to connect the. Just a minute. Just a minute because I have a problem in the internet.
Okay.
Sorry for this interruption because I don't know if the screen now appear.
Screen is there. Yes, appear.
You can see?
Yes, I can see.
You now connected the internet. I wish it would be. Okay, so if a patient with continuous leak, one of the differential diagnoses could be fistula, especially continuous.
Yes, fistula with continuous. Yes, with the There is sound, Lavinia.
Okay, so the answer is fistula. Urine retention
Yes,
with overflow,
yes, fistula.
especially the residual volume will be high. It will be more continuous in the continuous sleep, but usually in the exam it will be mostly fistula. I don't know if we have. I think we have very important one, but I think later because I don't want to put it early to not be confused. Thank you, Dr. Shazia, for sharing.
Doctor,
Just
for the question you asked, what's the answer? Just now you ask.
Retention is overflow.
What is high?
Urine retention was overflow. Yes.
Urinary retention?
Okay. Urine retention with overflow. Patient will have retention, and with the overflows, you will have started to have dripping of urine. She will have continuous leak. But if you examine this patient abdominally, there will be a full bladder. Before we can, yes, I will provide a recording for the session problem. Just there is one chart more I will bring because it's really important, but I make it later because this is maybe making confusion. So I will I put it later. Okay. I will talk about this is usually done for the patient who is avoiding the problem that the electricity cut. So I'm using alternative internet. I don't know if it's clear or not. Clear?
Yeah, clear, Doctora. Sometimes
Yes, clear.
Clear. Okay. So in the first, the other one, uroflowmetry, this is another type of the study. The patient, there will be also a special equipment, and we will ask the patient to urinate in this.
Your voice was breaking. So you asked one question that if the post-residual volume is high, then what will be the answer? What would be the answer?
Urine retention with overflow. Urine retention with overflow. Okay. Yes, because the patient will have continuous leak, but this patient, she has urine retention. The bladder is full. Okay. The screen, what screen you see now in the, what is the screen you are seeing now? What is
the answer for that question?
Fistula.
Oh. So
no new slide,
screen is not moving.
Yeah, no new slide.
The screen not moving.
Yes, seem like not moving.
I don't know. So what is the solution? I don't have solution because the problem there is no electricity. I don't know.
New screen came.
I think
New
now
screen.
correct.
Yes.
Good. Okay. The other type of study, will be uroflowmetry. Uroflowmetry, like the patient, she will complain of voiding dysfunction. So we'll ask her to void in a special equipment, like in the picture. For the male, it can be when they are standing. For female, she needs to sit in a special commode, and this uroflowmetry will record how much volume she passes and also the speed of urination, and when will be the maximum flow. This will be normally bell shape, as you are seeing in the picture. The most commonly come in the exam is the cystometry, what we are discussing mostly, but sometimes in the exam he can put a question about uroflowmetry, especially there is one talk articles, I think 2019, they are talking about uroflowmetry. So could be one question about uroflowmetry. So we don't want to miss any mark in the exam because this will increase the chance to pass the exam. So normally it should be bell shape. The peak flow rate, they are putting like Q maximum. Q in the exam, it can be Q max. This is the maximum peak flow rate. It should be more than 15 milli per second. Flow time should be within 30 seconds. The patient, she can evacuate her bladder within 30 seconds. This is normal. The peak, how much? It should be the peak, the speed should be 15 milli per second. It should be how will be the shape? It should be bell shape. So if in the exam he give you the peak flow rate low. Be careful and concentrate well in this point. If he give you the flow rate low, we tell how much should be the peak flow rate, should be more than 15 milli per second. He give you in the exam 2.6, 3, 5. So this is low. Be careful because this can be a question in the exam. So if he give you the peak flow rate low, so either this patient, she has outflow obstruction, there is obstruction, or this patient, she have hypotonic bladder. The bladder is weak, so the flow also weak. Patient can't urinate, or the patient want to urinate, but there is obstruction. So how I will differentiate? He gave me the flow, the maximum flow rate low. How I will tell that this is outlet obstruction or this patient hypotonic bladder? I will look to two things. How much is the trouser pressure and urethral pressure? If both high, so this patient wanted to push. She wanted to push the urine, but she can't. There is obstruction. So if the trouser pressure high and he give you urethral pressure high, so this patient, she has outlet obstruction. If the trouser pressure low, and the urethral pressure normal, so this patient, she has a problem. The bladder can't patient during the voiding phase, the contraction will be normal because the patient, she will void. So it can be reached to 50, 60, 70, no problem. But if it is very low, the patient, she can't pass urine. So how I will confirm in the exam? If he give me low maximum flow rate, so either this patient urine obstruction, outflow obstruction, or hypotonic bladder. How I will confirm? Just to look to the patient. If there is pressure high in the trouser pressure, patient wanted to push, and the urethral pressure high, this patient wanted to push urine, but there is obstruction. This is from TOG articles 2019. This is chart, the most important, all important. But for me, this is the most important one. We just discussed now. When reduce the maximum flow rate, this will be the most important one. Sometimes the patient, she have very active. So if it will be like the peak and the down stroke, it will be very short time. We tell it should be within 30 seconds. It can be very short time. So it will be like this. Sometimes the patient, she will have, if you ask her repeated Valsalva, she is trying to pushing and Valsalva again, it will be looks like she wanted to, it will be like this shape. But the most important one for the exam, usually it will be this time. But this is not mean that the others will not appear, no. He will give you the flow rate low, and he asks you what is the diagnosis, so you will look the trouser pressure very high, this is obstruction, because the patient wanted to push, but there is obstruction there. This is TOG article 2019. Again, overactive bladder syndrome, if you diagnose the patient with symptoms. The trouser overactivity, if I see in the urodynamic study. I need again to how I will confirm that this is against the trouser overactivity when I look to the first void. If the first void less than 150, this is patient also, she have the trouser overactivity. If the bladder capacity less than 400 milli, this patient also, she has the trouser overactivity. During the filling phase, should be no any contraction in the trouser muscle. If there is contraction, either one more than 15 centimeter water or frequent contraction more than 5 centimeter water, this patient also, she has the trouser overactivity. This is during the filling phase. If she has leak with this will be trouser overactivity with wet type or dry type if there is no leak. In the start, we will ask the patient if she come to the clinic after taking a history from her and examining her and send the investigation and confirm that this patient don't have any urine infection and give her blood or diary. After this, we will start to counsel the patient regarding what will be the conservative management, like lifestyle modification. If she is taking much caffeine, she need to decrease. She need to modify the fluid she is drinking per day. need to treat the predisposing factors, like she has chronic cough, chronic constipation. This all can help the patient and improve her condition. Bladder draining, we will talk about how the patient she will do, because this is very important, how to teach the patient regarding bladder training, because, and don't be confused regarding bladder diary, because this is, can happen, and the bladder training. Bladder training, this is a treatment. Bladder diary, this is investigation. To understand what happened, why is the patient she will complaining, what is the problem of the patient with overactive blood as a clinical diagnosis. Usually anyone, when the bladder will be filled with bladder, with urine, he will start to want to pass urine. So this scan, patient can accommodate about 400 milli urine or 600, from 400 to 600 maximum. Too much hot. Too much hot now. Okay. The point of the bladder will fill by about 400 to 600 urine. This will be normal. But if the patient just minimal amount of urine and she will start to rush to the bathroom, will be this patient she complaining of overactive blood. This is clinical diagnosis. So just a small amount of urine, she will need to rush to the bathroom. Either she can tell you, doctor, I go every 30 minutes, and this is not normal. And this can affect much by the social habits, like she's drinking alcohol, or she's a smoker, or drink much caffeine. So the patient, this can worse her condition more. Either this will be a wet pipe, patient tell you, before I reach to the bathroom, I wet myself, or she can tell you, doctor, no, I can reach to the bathroom and also I am dry, so this will be the dry type. Okay, we can ask someone to share, who wants to share. Hello?
Samri, I will tell Dr. Khater. Doctor, I will do
Shazia. Okay, Dr. Shazia,
Yeah.
okay. We can take 5
what
questions.
is the most
Okay.
What is the most common type of urinary incontinence in European women? I think it is stress incontinence.
How much percentage?
I'm not sure, but I think it's stress incontinence.
About half.
40,
about
49%. 49%.
50%. 50%.
Just we will think about half of the patient, so it's easy.
Okay. Patient with overactive bladder, how much percent she will have incontinence? Overactive bladder, she will have incontinence.
Just now we tell some patients you will have incontinence. Some patients you will have incontinence. Some patients she tell, no, doctor, I don't have incontinence. Correct? Just now we tell. So how much they will have leak? Only 30. So 1/3.
Only
easy. 1/3. 1/3. Easy?
Okay. Yeah, easy.
1/3.
What is the most predominant symptom of overactive bladder in women? Frequency, urgency, nocturia, and uresis. Urgency, I think so.
Urgency. Urgency, the most predominant symptoms. Urgency. Excellent.
Yeah.
Urgency.
Yes, First line investigation for women with urge symptoms. Bladder diary, urodynamic, ultrasound, bladder diary.
First line treatment for the patient. Correct. Bladder
Investigation.
diary. Excellent.
Investigation. Bladder diary.
Yes. Investigation. Bladder diary, the patient, she will take this diary. This will include 3 days. Usually they are working 2 days work, and 1 day when she is off from her work. She will recording in the bladder diary how much fluid she is taking, how much volume of urine she pass, if there is any leak, if there is any urgency. So this will be over 3 days. Don't be confused between bladder diary and the bladder training. Bladder diary, this is investigation. This will be initial investigation with the urine sample to confirm no infection. Bladder diary, this will be a treatment. Bladder training, this will be a treatment.
Yes. overactive bladder patient who drink decaffeinated drinks, best management. Bladder retraining, bladder diary, then bladder retraining, I think. Yeah, bladder, overactive bladder who drink decaffeinated drink, best management. Bladder retraining.
Brother retraining. Okay, just I will connect
Yeah.
to the other internet because just a minute. Okay, just a minute. Okay, so okay, now bladder training. How the patient she will do bladder training? She will tell you, doctor, I will go to the bathroom. I will rush to the bathroom every 30 minutes. Either she will wet herself or she will not wet herself. So her complaint, she is working. And this can affect her work. You can imagine if someone in meeting and he wants to rush to the bathroom because she can have incontinence. This can affect her life much. So she can tell you, doctor, every 30 minutes I need to rush to the bathroom. Either she wetting herself or not. You will tell her, so every 30 minutes you are going to the bathroom. She will tell you, yes, doctor. So just you will tell her, if you possible, try to hold yourself at least 10 minutes. If possible, you can. Sometimes she can't. You can tell her, even you can try 5 minutes. So whatever she can try, either 5 or 10 minutes, you can try this one for 1 week. Every time you want to rush to the bathroom, every 30 minutes, you can hold yourself more for 5 minutes, 10 minutes. Yes, I will try. So next week she tell, yes, doctor, I can hold myself for 10 minutes extra after the 30 minutes. You will tell her, can you try next week for 15 minutes? You can try. So next week she will try again. When she wants to rush to the she will hold herself for 15 minutes. After 1 week, she tell, yes, doctor, I can hold myself 15 minutes above the 30 minutes. You can tell her, well, you can increase more to 20 minutes until the patient, every week she will increase gradually as she can, until the patient, she can hold herself for 3 to 4 hours. This will help the patient because she is doing like exercise for her bladder. This is bladder training. She will try for how many? For 6 weeks. Don't forget.
Yes,
6 weeks. Please close your camera because the session will be posted in YouTube. I don't know how also to do montage for anything. Just to close your camera, doctor, please. Doctor, don't know her name. Can you please mute your camera? Close your camera. Okay. So the patient will tell her, modify, if you are drinking caffeine, try to decrease the caffeine because this is mainly will help her in the overactive bladder. Other things like modify the fluids intake, like decreasing hormones, this will help her generally for other types of incontinence with the incontinence. Yeah.
Yeah, patient has symptoms of overactive bladder. She tried bladder training with no response. What is the first line drug choice for the following according to the NICE? Oxybutynin. Oxybutynin is the first choice.
What is the mode of action of oxybutynin?
Oxybutynin, it is antimuscarinic drug.
Anticholinergic.
Anticholinergic.
Yeah.
Anticholinergic.
Yes. It's anticholinergic drug. Yes.
Thank you, Dr. Shazia. How many questions you take now? How many? Because we much. Okay.
I don't know.
I will just comment. Okay. Okay. So the medical treatment now we tell patient with overactive bladder. She will come to you. You give her. You check if there is infection or no. Then you send for you give the patient a bladder diary for 3 days. After this, you give her conservative management, like you tell her decrease the caffeine or stop caffeine, modify your treatment, stop alcohol, stop smoking, decreasing your weight, all conservative, and you try for her bladder training for 6 weeks, and still she is complaining. So I will do next, I will start medical treatment. Medical treatment, this will be the anticholinergic drugs. This is antimuscarinic drugs, oxybutynin, tolerdine, darifenacin. Sometimes the patient, she will tell you, I can't, doctor, withstand the side effects, because the patient, she will complaining of side effects, and before you start even the treatment, you should tell the patient what is the side effect she will expect it. Like dry mouth, like constipation, we will discuss the side effect later. But you should tell her that the side effect means that the drug started to work. So you will tell her the side effect before you are prescribing any treatment for any patient. She should inform her about the side effects. If she tell you later, I can't withstand the side effect, it's effective and it is control my symptoms, but I don't want the side effects, so you can try with her transdermal oxybutynin. This can be a question. So the patient, she try, it's effective, but she can't withstand the side effects, so transdermal oxybutynin can be a treatment option for her. Oxybutynin, if they give you patient old woman, frail woman, don't choose oxybutynin, because this is crossing the blood-brain barrier, and this can affect the cognitive behavior of the patient. So don't use oxybutynin in patient frail old woman. If he give you a scenario of nocturia, desmopressin can be option for the patient. And if the patient also, she have, sometimes can be the patient also, she have dryness or problem in the vagina from post-menopause, estrogen cream also can be one of the treatment offered for the patient. Caution for desmopressin, if the patient, she has cystic fibrosis and the patient over 65 years with vascular and or hypertension. Suppose you give the patient the 3 antimuscarinic treatment, oxybutynin, tolerdine, darifenacin, and she tell you, doctor, it's not effective at all, because usually you will give her appointment after 4 weeks. So in every 4 weeks you will try another new. But she tell doctor it's not working at all. Then you can choose for the patient, if not effective, so you will choose mirabegron. Mirabegron, this is beta-2 adrenoreceptor agonists. They are not trying the mirabegron in the start. Why? Because this is expensive drugs. Because when we are treating any patient, the aim to decrease the cost. So you can't use a mirabegron in the initial treatment because this is very expensive drug.
Doctora, which time I will use oxybutynin or tolerdine? You told that immediate release for both of them. I can give either this or this, or
he can sometimes he can give you patient what is the first line treatment, so it will be oxybutynin. If he give you the patient frail woman, so you can choose other types like tolerdine or darifenacin. If he tell you patient want to treatment with once daily preparation, so it will be darifenacin. Okay. If he give you the 3 treatment antimuscarinic treatment tried and no response, so he want to use mirabegron. If he tell you it's effective but patient can't withstand side effects, so you will choose transdermal oxybutynin. Okay. Still we will have a questions. There is a questions. I'm putting a questions to practice the same questions. The patient, after you give her any new medication for overactive bladder, she will come after 4 weeks. Either she will come to the clinic or by telephone, no problem. So both, she can, if she wanted to come to the clinic, no problem. If she wanted to talk by telephone, no problem. She will tell if there is improvement or not. If there is no improvement, again, I need to choose another treatment and try another treatment with the patient and see if there is response or not. And again, she will need to come after 4 weeks. If she tells me I have, so when I come to the clinic, so she will come to the clinic according to her age. If her age more than 75 years, this patient needs to come to the clinic every 6 months. If the patient less than 75 years, this patient can come yearly. So she can take the treatment and she can come yearly for follow-up in the clinic. This will be a long-term medication. So before start any medication for the patient with overactive bladder, we need to inform the patient, explaining for her how much the treatment will be successful, What is the commonest side effect of the treatment? Like dry mouth, like constipation, and we need to explain for her. Once you started to complaining of these side effects, this means that the drug started to work. We talk about the point when she will come. It can be take over 4 weeks until will be effective. Contraindication. This is even anyone will do interview for the consultants. They will ask you a question regarding anticholinergic drugs. What is the common side effect? This is if anyone will have a meeting for the consultant interview. This is a common question for the urodynamic. What is the common side effect of the anticholinergic drug? Dry mouth, constipation, blurred vision, drowsiness. If you remember the other, any drugs, nausea and vomiting, this can put for any drugs generally. Contraindication, myasthenia gravis, glaucoma, ulcerative colitis, and gastrospinal obstruction. Others is caution, but the most important is the contraindication. This should not be given at all. Myasthenia gravis and glaucoma. Don't forget these two indications mainly. Ulcerative colitis and gastrointestinal obstruction. Okay, who wanted to share? Hello?
Hello.
Can I, ma'am?
Okay, Dr. Nikhat.
Nikita, ma'am.
Nikita. Okay, Dr. Nikita.
Patient has symptoms of overactive bladder.
Dr. Nikita,
She
okay.
tried. Patient has symptoms of overactive bladder and she tried bladder training with no response. Now she started anticholinergic drugs, but she can't tolerate the side effects. What is the treatment of choice according to NICE? Darifenacin, solifenacin, duloxetine, mirabegron, and transdermal oxybutynin. She can try transdermal oxybutynin.
Dr. Nikita, no voice. Dr. Nikita.
Hello.
Dr.
Can you
Nikita,
hear me?
no voice. Hello.
Can you hear me? Can you hear me?
Yes. Yes, I can hear you now. Yes.
Okay, so the answer will be transdermal oxybutynin. We will change from oral form to transdermal form.
So the patient here, she started already anticholinergic, but she can't. It's working with her, but she can't tolerate the side effect. So we can choose something less expensive. So it will be transdermal oxybutynin. Correct. Why transdermal oxybutynin in the side effects mainly? Because this will avoid the hepatic first path metabolism, and this will decrease the systemic adverse effect.
Yes, ma'am. Thank you.
Next. Continue. Where are you? Dr. Nikita.
Yes, urinary incontinence in 82 years old treatment. She tried bladder training, was not effective. Trospium.
We can answer in the exam by exclusion. Sometimes I don't know the answer, but I can look for the others. If can be used, then I will tell no, can't be used. So I can. It will be the answer.
Yes. So she's 82 years. She's old and frail. We cannot give oxybutynin because it crosses the blood-brain barrier. Mirabegron is an expensive option. Trospium is a choice, and duloxetine cannot be given. So I feel it's trospium.
Yes, duloxetine. This is for stress incontinence. Oxybutynin can't be used for patient frail woman because this is Dr. Zainab. If you can mute yourself, Dr. Zainab. And the oxybutynin will cross the blood-brain barrier, can't be used in the patient frail woman. And mirabegron, this is expensive drugs. We can start by other antimuscarinic, so it will be trospium. Correct. This is also anticholinergic drug. Next. Dr. Nikita, where are you?
I'm not able to see the screen. Yeah.
Okay.
An old lady with overactive bladder who had received 3 antimuscarinic drugs, no improvement. What is the next best treatment to offer? Mirabegron, trospium, duloxetine, oxybutynin patch, MDT referral for urodynamics. So it is not like she's not tolerating, but she's not improving. So next we will go for mirabegron, which is beta-3 adrenergic agonist.
Yes, patient is try 3 antimuscarinic, and usually they are giving the low cost. So they want to try expensive drugs, so we can go for mirabegron, as she tried already 3 antimuscarinic treatment and not working. Okay, so
Yes,
the
ma'am.
answer mirabegron. So here, you remember the first one, she can't tolerate, so we can give her transdermal. Here, no improvement. No improvement, so we need to choose mirabegron because she's already tried 3 types of antimuscarinic drug. Mirabegron, we tell this is selective beta-3 adreno receptor agonist. We tell it can be used if the patient there is antimuscarinic contraindication or clinically ineffective or unaccepted side effects. Unaccepted side effects, but if we have transdermal as a choice, it should be the first because it will be low cost. Still, we can use mirabegron. Okay.
Okay, ma'am. An old lady with overactive bladder who had received 3 antimuscarinic drugs and mirabegron, there is no improvement. What is the next best treatment to offer?
She tried already 3 antimuscarinic and the mirabegron and no improvement.
It is saying overactive bladder, which means that they have not done the urodynamic studies for her. So we can do the urodynamic studies and treat accordingly.
So you will choose urodynamics. In the exam,
Yes.
sometimes someone will tell why you bought mirabegron. Already it's written in the question, she take mirabegron. So why mirabegron is an option? Because in the exam, because sometimes when you are in hurry or you under the stress, just you will see patient with overactive bladder who received 3 antimuscarinic and you are solving much questions. So you tell she used 3 antimuscarinic, not working, mirabegron. It's there. But it's written in the question that the patient use also mirabegron because the scenario will be long. You will lost. So you should concentrate what is the information they given to you. This is happen in the exam. In the real exam, this is happen. You can miss very important information they given in the question and you miss it and it can change the answer of the question. So here the patient should try 3 antimuscarinic treatment and again she start mirabegron, no treatment, so we need to do urodynamics for the patient. Urodynamic we are doing for the patient if she not responded to the medical treatment. We are offering the treatment to confirm what is the diagnosis. Either she is the detrusor overactivity or there is no any detrusor overactivity, so this patient will need further MDT to check what is her problem. If she is a case of detrusor overactivity, so we are going to further management of detrusor overactivity.
Doctor, for overactive bladder, we will treat before urodynamic. Before we will do urodynamic, we can treat. We can use treat before.
This is the steps according to NICE guideline. You will start first conservative, bladder training, anticholinergic, mirabegron, then urodynamics, then invasive procedure. This is the steps. This is NICE guideline. This is the steps in the NICE guideline.
We will give anticholinergics for how long, ma'am?
Every 4 weeks, she will have appointment. If you start a new treatment, the patient, she will come every 4 weeks. Every new treatment. Every 4 weeks, you will check the response. If you try 3 antimuscarinic, you can move to the mirabegron because mirabegron is expensive drugs. And after this, if the treatment not working with the patient, you need to do urodynamics for the patient. Okay? The patient, one of the, after the MDT, after urodynamic, this patient, you can do for her further treatment after MDT review. This is will be botulinum toxin A. Botulinum toxin A, not B, because sometimes in the exam he can put for do, you know the botulinum toxin, but you don't know which type, and in the exam you are confused. He put type B, type A, so we are not using B. We are using only type A. When we are injecting the patient with botulinum toxin A, we need to inform her about what will be the prognosis. So we can tell her you could have complete symptoms relief, could be partial relief, could be you have retention and you need clean intermittent catheterization. You could need a catheter for some times if you don't want to do intermittent catheterization. There is risk of increased urinary tract infection. So in the exam, if he give you a scenario and he tell you patient try all the treatment, medical treatment failed, urodynamics detrusor overactivity, patient will not well to have risk of catheterization. He wanted to tell you don't choose this option. He don't want patient tell you I don't want any risk for catheterization. So he wanted to remove the option of botulinum toxin A as an option for the patient because she tell you I don't want any risk of catheterization. So this patient could need partial removal, partial or complete, and she could need intermittent catheterization. You take this question now. Okay, continue. Who is the doctor? Last doctor was us who's talking. Doctor.
Yes, yes, it's me. Yes, it's me. The initial dose of botulinum toxin type A to treat overactive bladder in women will be 100 units.
Yes, 100 units. If someone reads the old guideline was 200. And they put, if the patient don't like to have the risk of catheterization, you can start by 100. But in the recent guideline, they tell the first initial diagnosis 100 for all. So be careful if you have summary from the old guideline, be careful. The initial diagnosis now only 100 units. This is a picture. This is the Botox. They will inject in the bladder wall, like in the picture here, and this is will help the patient. This is will cause like relaxation in the bladder muscle, and this is will decrease the symptoms of the patient. Patient here, either again, you remember anticholinergic, she will come after 4 weeks, either come to the clinic or call by telephone. Here the patient will come within 12 weeks. So 4 weeks is the first one. Here, no, she will take longer appointment, 12 weeks, to see if there is improvement or no improvement. And we will teach her regarding a clean intermittent catheterization. We offer botulinum toxin A, not B. Either she will tell you, I have got symptoms relief, doctor, and there is no any symptoms now, so it's okay, and we'll tell her when she will come again. Either she will tell you, doctor, I have inadequate symptoms relief. So again, we need to increase the second dose to 200 units and review again within 12 weeks. If no effect at all, this patient needs to be seen by MDT again. If the patient, she has symptoms, but still the symptoms again occur less than 6 months, she tell I have improvement, but still, doctor, I have again symptoms, but the improvement not lasting more than 6 months. So again, she has the symptoms again this 6 months. So again, this patient, she will need second dose. So either inadequate relief or no. Take care from no effect. No effect, patient same. Patient same, don't have any improvement. So this is MDT. Inadequate symptoms or patient, she has adequate improvement, but the symptoms recurrent again less than 6 months. So she will need again second dose, but by botulinum toxin A, but here we will increase the dose 200. So the first initial dose 100, the second dose will be 200. I think there was one question, I don't remember in which book, I don't remember now. Before you are injecting the first botulinum toxin A, we will refer the patient MDT before injection. For the second dose, you are injecting the second dose, no need for MDT. So you can inject the second dose immediately. Be careful from this point. So before I inject the first dose, MDT. For the second dose, if inadequate symptoms relief or there is adequate improvement, but the symptoms return less than 6 months, you can inject the second injection 200 without MDT. Okay, Dr. Nikita?
Yes, ma'am.
Hello?
Yes, yeah, I'm here, ma'am. Can you hear me?
It's a question.
I'm
Yes,
not
I can hear
getting
you.
the,
Read the question.
yeah. 67-year-old woman is seen in gynecology OPD. She has tried various medications for detrusor instability and all has failed. She don't
There
want
is much interruption, Dr. Nikita. There is much interruption.
Can you
There is
hear
much
me?
interruption in your voice. No, I can't hear you. If possible, you can near to your router because I can't hear you. Hello? Hello?
Yes, yes.
Okay. You can read the question. 77-year-old woman seen in gynecology outpatient clinic. She has tried various medication for detrusor instability and failed. She don't want. We can take another one to share. We can take another one to share.
I can read,
But
Dr.
please
Kafaza. I can read.
Close your camera. Close your camera. Okay, what is your name?
Yeah.
One not share before. Doctor who?
No, can I read, Dr.
Hello?
Ghada? This is Dr. Uzma here. Can you hear
Anyone?
me?
Dr. Ozma, I want someone with clear voice, so it will be it will be clear in the
Can
recording.
can you hear me?
Yes, Dr. Ozma, you can continue, Dr. Ozma. Okay.
Yeah, I can, but this is a very difficult topic. Always has been difficult for me.
No, nothing
I'm
difficult.
sure you'll help me out with this. I'm going to read this very clearly. You can help me out with this. Yeah, a 67-year-old woman is seen in the gynecological outpatient clinic. She has tried various medications for detrusor instability and all have failed. She doesn't want. She don't want that. They are not prepared to. But she doesn't want to accept the risks of needing the catheterization. So, which of the following options would be most appropriate for her? One is bladder distension. B is botulinum toxin A. And percutaneous sacral nerve stimulation. D is transcutaneous sacral nerve stimulation. So this lady is 67-year-old. She does not want, she has a detrusor instability, but she does not want catheterization. So bladder distension is ruled out, botulinum toxin A is ruled out. If she has already attended MDT, we can try for percutaneous. Can we try for this? See, percutaneous sacral nerve stimulation.
Yes, because already she tried the medication, not working with her. Various medication, she don't want to take the risk of catheterization. Now she is for surgery, so don't want catheterization. She will remove. It should be botulinum toxin, but as a treatment. But if the patient tell you I don't want risk of catheterization, so he wanted to tell you don't go for the botulinum toxin A. So it will be percutaneous nerve stimulation.
Yes.
Like it?
So do I read this? Yeah, okay. A 67-year-old. Yeah, okay.
Who is talking?
Okay. A 67-year-old woman is seen in the gynecological outpatient clinic. She has tried various medications for detrusor instability and all have failed. And she's keen to try the least invasive procedure. That is, which of the following options would be appropriate for her? One is bladder distension. B is botulinum toxin A. C is percutaneous to posterior tibial nerve stimulation. D is percutaneous sacral nerve stimulation. And E is transcutaneous sacral nerve stimulation. So she does not want, she wants a least invasive. So botulinum is out, it is not, it is invasive. Percutaneous, transcutaneous. So which one will it be?
Least.
Least is posterior tibial.
Yes, posterior tibial nerve.
Posterior tibial
all invasive.
Yes.
All invasive. Botulinum toxin A invasive. Sacral nerve stimulation. This is invasive. Posterior tibial nerve stimulation. This is also invasive. But the least one will be C.
Yeah. Because I think sacral will be more invasive.
Posterior tibial nerve stimulation. Next.
Yes. Okay. Let me see the question. I can't.
Okay.
No.
Just so the invasive procedure, if the patient not respond to the medical treatment, we tell before, if no respond to the medical treatment, before we are going to the invasive procedure, we are doing urodynamics. Urodynamics, why? To confirm the diagnosis. This is
Okay.
posterior tibial nerve stimulation. This is will be
Yeah.
3 to 6 centimeter above the medial malleus. The treatment will be about 30 minutes, half hour the session, about 8 to 12 sessions. So the patient, she can come for 8 sessions, 12 sessions according to her improvement, and this is will be the least invasive maneuver for the patient.
Okay, good. You're
This is the
doing it
sacral
beautifully,
nerve
Dr. Ghada.
stimulation.
Your lecture has been
Monsieur.
very, very helpful and very beautiful. I am for the first time understanding urodynamics.
Thank you, Dr. Uzma. If you repeat, we are not a urologist again. Just we need to know the basic. Just we need to repeat the information. Don't go deep. They don't want from you to be a urologist, but you need to know the basic informations about urodynamics and incontinence, because you will be the first one to see this patient before you are referring. So you can do initial management, conservative management. So when you are going to refer the patient, all this is very important. This
Yes,
is
doctor,
sacral
thank you
nerve.
very much. Without
No
these
problem, Dr.
figures,
Uzma.
I
Welcome.
don't think we could have understood anything.
I just try to make it simple by the pictures. I try to bring much pictures from Google and also from the TOG and book to make it easy for you. This is the sacral nerve stimulation. This is will be, you know where they will insert this one electrode, Dr. Uzma? Do you have idea where they will insert in the sacrum? At which level?
At
which?
S2, 3.
3, S3, S2, 3.
2,
I
3,
don't know.
4.
So that should be the
S3
pudendal.
in some box,
Yeah.
S3 in some other box, S3 is S4. So between S3 and S4.
S3 and
they
4.
will inject first they will try before because this will be permanent, about 5, the battery will be enough for 5 years. So maybe when you put the sacral nerve stimulation, maybe the patient will not feel any improvement. So first they will try a temporary one for 7 days. Then they will check if there is improvement, like reduction more than 50% of the symptoms of the patient, so they can insert the permanent one, because this is invasive. They will insert in the sacrum itself. So the first they will try temporary one, and after this they will start to insert the permanent one, as in the picture. If you look to the picture here, and this one will have battery, and this battery will need to change it every 5 years. Battery, because the battery will also need to be changed, so it will need to be changed every 5 years. This will have also side effect, because you are inserting something in the under the patient's skin. So this can have electrode migration. There could be failure. Maybe there is no any effect. Maybe failed with the time and not. Maybe need re-operation again. How much percent they will need re-operation again? About 1/3 of the patient, and it's very expensive. It's reached to $15,000. So it's very expensive and need also lifelong follow-up for the patient.
I want to ask you a question, Dr. Ghada. Is this available in the
suppose
NHS?
all this treatment. What?
Is this available in the NHS?
No, I'm not sure about this point, if it is available in the National Health Service or not. I'm not sure.
Oh, okay.
The point here, if there is, I think $15,000 will not be available anywhere. It's much cost. I think it can be. I'm not sure from this point, but if something indicated, just as you will see if it is refunded by the National Health Service, and they will give approval for this or not. So they can apply for approval. So it's approved or not, I'm not sure. Don't go outside the main points of our exam now. The point of if all this treatment is tried for the patient and still the patient complaining, still you need to do solution. If you try all, botulinum toxin not work, all you try, so this patient needs another treatment, because this is affecting her life. So augmentation cystoplasty, this is another option for the patient. They are taking part from the ileum, as you see in the picture, and they are doing enlargement of the bladder. So this is also can be option, but also this will be operation with side effect. Like the patient, she can have intestinal obstruction, she can have adhesion, she can have bladder rupture. This also part of the ileum can be also causing fistula in the long time between the bladder and the wall of the ileum used. This can cause fistula, but this is still an option for the patient, augmentation cystoplasty. Urine diversion is still another option for the patient. We are not we are removing the bladder at all as an organ, and we are bringing part from the ileum, and this part will be opened outside the patient abdomen, so the patient will not have any incontinence. This is can used in the cases not respond at all to all the treatment, but the patient, this is affect her social life. She tell I want solution, so this is only in the very few cases it can be options for them, because all other treatment not working with her. But this is also can have side effect like they can have renal stone, renal failure, ischemia from the ileum. They are using as connecting the urine from the ureter. Okay, next, Dr. Uzma.
Yeah. 54-year-old patient complaining of recurrent urinary tract infection and microscopical hematuria and mixed incontinence. So the investigation you do is either urodynamics, B cystoscopy, bladder diary. I think if she has hematuria, you go for cystoscopy to rule out.
Yes, we just take
any pathology.
Start in the session. If the patient has frank hematuria less than 50 years, she tell you I have pure blood in the urine. Frank hematuria less than 50 years or microscopical hematuria more than 50 years, could be a case of cancer. So will be cystoscopy. This is the referral. This is also from MRCOG articles, pathway of referral. If the patient more than 50 years with microscopical hematuria, or patient with visible frank, you can see by your eyes. More than 50, it is microscopical hematuria. Next, Dr. Uzma.
What's the most likely diagnosis? 20, a patient 60-year-old with recurrent UTI and hematuria. Given the picture A, I think this is a bladder tumor.
Bladder tumor. Okay, cystoscopy, there is something inside mass. Patient, she has hematuria more than 50 years. This is a case of cancer. So will be bladder tumor.
Yes.
Okay.
I read the second one. 21.
Yes.
The patient with 35-year-old patient complaining of urgency, frequency, and lower abdominal pain. Last 5 urine culture showing either no infection or mixed growth, no response to antibiotics. The following cystoscopic picture is this. This could be in interstitial cystitis.
Okay, why you not used overactive? Why you didn't use F?
Yeah, bladder pain syndrome. Painful. Yeah, interstitial. Why? Because of the picture, Dr. Ghaza. Because of the picture I saw.
Yes, okay, because already it's the same idea. I already diagnosed. I see by my eyes in cystoscopy. So maybe in the start I diagnose this is bladder painful syndrome. This is clinical diagnosis. But once I see by cystoscopy, will be interstitial cystitis.
Yeah, that's true. Okay.
Any other you want to share?
Yeah, anybody else? Yeah.
I want to share.
Okay, what is your name, doctor?
Hassan.
Yes, Dr. Hassan. Okay.
Patient with stress incontinence, first line treatment.
Patient with stress incontinence, first line treatment.
Pelvic floor exercise.
Okay, C. Next.
Overactive bladder plus stress urinary incontinence asked for treatment. Overactive bladder plus stress incontinence.
Overactive bladder plus stress incontinence. She has to complain.
E.
Anticholinergic drugs. Why? We will start step by step. We don't want to rush to further management. First step, second step. So what is the first step? Patient initial management. We need the initial management.
Bladder training.
She is a case of overactive plus stress incontinence. So she has to complain. So you choose D. What is the answer?
B.
Dr.
Bladder training.
B. So 23, you choose B. Okay, 24.
Patient with multiple sclerosis and complaining of retention of urine. What is the treatment? She has multiple sclerosis, retention of urine.
Intermittent.
Intermittent.
Yes,
Yes. Clinic, you have here friend. You see, you can, but in the exam, no.
No,
Okay,
I want to like, I choose it.
okay,
I
no
want to
problem.
see.
We want the our volunteer to help. We want you in the exam also. If possible, you can come with us. Okay, G. Okay, okay. So the second one was wrong. Correct, the first one, pelvic floor exercise. But if you have patient with two problem, bladder, overactive bladder and stress incontinence, you can try both bladder training and pelvic floor exercise. Patient with multiple sclerosis, if she is comparing retention, because she will have frequent time, so you should teach her how to do clean intermittent pasteurization.
Dr. Ghada, sorry, what is the difference between bladder training and bladder retraining?
Both no, same.
Okay.
Both same.
Okay.
So the bladder, we tell again just a summary. Sorry, I think is this summary come late or what? Okay, no problem. Bladder again, the bladder overactivity. Patient come to you in the clinic after you confirm. You will give her initial send urine analysis, no infection. Bladder training done, bladder diary done for her. You give her bladder diary 3 days and she come back. Then you will start conservative management. Conservative management, bladder training. Bladder training will be for 6 weeks. Lifestyle modification, caffeine decrease, reduce her weight, modify her fluid intake. Pelvic floor exercise. Sorry, it will be first. Sorry, it will be only pelvic floor. Sometimes they are using. I think in one talk article it's using, but just to not be confused from the stress incontinence. Just I will remove this one. Then you will start the antimuscarinic treatment. We tell we have antimuscarinic several drugs. You will start first the cheapest one. If not work, we can go for mirabegron. Other treatment will be mirabegron if it is expensive. Desmopressin for nectaria mainly, and estrogen for the vaginal dryness. Botulinum toxin after MDT, sacral nerve stimulation, bladder augmentation, and urine diversion. Botulinum toxin they bring mainly from bacteria Clostridium botulinum. This is just a summary for the overactive bladder. Okay, next. This is the question I told before. Okay.
Patient complaining. Patient complaining of urinary urgency and frequency. Her urodynamic study done and normal. What is the diagnosis? Urodynamic normal. D. Because
D or B?
Because if the truth overactivity, urodynamic will not be normal.
Excellent. This is a very, very important question. This is very, and even in sometimes you can face this question in the OSCE exam. Any OSCE exam, MRCBI, MRCOG, Arab board, Saudi board, he can give you a urodynamic study. It's normal, and he will tell you patient is complaining urgency. So the drusen contraction during the filling phase. Urodynamic study is normal. So why is the patient she have urgency? So this will be sensory urgency. Don't go deep regarding this information to not lost. This is just sensory urgency. The patient, she will have the same symptoms of overactive bladder, the same symptoms, but the only difference between both, just in summary, because I searched for this point frequent times, the difference between both the urodynamic study will be normal in the sensory bladder. The treatment, usually it will be the same treatment. You are going to do conservative, anticholinergic, and even you can inject botulinum toxin. It's a nice guideline. Even root-to-trouser contraction, you can also try. So in summary, sensory urgency, if patient, she has the same symptoms of overactive bladder, but when you do the urodynamic study, it's normal. Don't talk more about this point to not be confused, because this is appeared before in some OSCE exam, and it was difficult task because the examiner gives the task, this is a urodynamic study, and the patient complaining of urgency, but there was no trouser overactivity. So what is the patient diagnosis? So this will be sensory urgency. So no motor function problem in the patient bladder. This is just sensory nervous. Patient, she will need to rush to the bathroom because she fear of leak or fear of pain.
Dr. Gada, what about the option A, overactive bladder? Can't we say that it is an overactive bladder?
Overactive bladder, this is the initial diagnosis. But if I confirm by urodynamics that this is patient not the trouser overactivity, so from the start this is not a case. I am suspecting that this is a case of overactive bladder. But when I wanted to send the test, urodynamics, it's confirmed that this is not a case of overactive. But if it is confirmed, so my suspicion from the start, it's normal. So if urodynamics study normal, and this patient, she has the symptoms of overactive bladder, just make it in this way to make it simple. Don't be confused, because if you will become confused, you can lose also marks in the exam. Just to put rules. Patient to urodynamic study normal. Patient, she has the symptoms of overactive bladder. This patient sensory urgency. Finish. Okay. Remember, we are not a doctor. Okay. Just I will move now to the stress incontinence. Every time I will tell myself I will not pass 2 hours. This is, I think even we will finish in 1.5 hours. Until now we finished 2 hours, still we didn't finish, but inshallah we'll finish soon. The normal bladder, normally when anyone will have urine in the bladder, when he is coughing, here the muscles around the urethra will close. So anyone coughing will no leak occur. But in stress incontinence, there will be weakness in the muscles around the patient urethra. So once she will vomit, she will have like sneezing, coughing, exercise, she will leak. So this patient, she has stress incontinence. So if we clinically diagnose, this will be stress incontinence. If we confirm in the urodynamics, this will be urodynamic stress incontinence. Okay, Dr. Hassan.
Yes.
So the first line treatment, we tell lifestyle modification, pelvic floor exercise. Pelvic floor exercise, it can, we will talk now how many duration will be for the pelvic floor exercise. Continue.
Patient has symptom of stress incontinence. What is the first line drug choice from following according to NICE?
Stress incontinence, now you have stress incontinence, the first treatment. First treatment.
Pelvic floor physiotherapy.
Yes, drug, it's not suitable for the question. It will be the first treatment. Management. Okay.
Yes. B, the answer is B.
There is no first line treatment drugs for the stress incontinence, by the way. There is no drugs. The drug is not the first choice at all. Yeah. Okay.
Yes.
Sleeping, I tell you before, sometimes I'm sleeping during the preparation of the session. So no problem. Pelvic floor exercise. We are examining the patient in the start to check digital examination to check if the muscle, there is muscle tone, because the pelvic floor exercise will be beneficial for the patient. So the routine digital assessment for the pelvic contraction before the pelvic floor to check if there will be response or no. So if there is effective. Next, Dr. Hassan.
Slide not come. I'm not see another slide.
Really?
Yes. Same question.
I think my internet finished. Just a minute.
Now came.
It's there. Came, okay.
Yes, patient has symptoms. Patient has symptom of stress incontinence. Plan for pelvic floor exercise. It should be at least 3
B. 3 contraction 8 times per day for 3 months. So it's wrong.
C. Eh?
Why C? No, I will tell you. I am before my exam. I'm much confused about this answer. So I remember how really I confused 8 contraction or 3 contraction. Just I tell the patient with each diet per day, she need to have contraction. So how many times per day she will do? She will have 3 times per day. It's easy with the breakfast, with the lunch, with the dinner. So 3 times. In each time she needs to do 8 contraction. For how many duration? For 3 months. Easy. I will not forget. I will not forget for my life. I will do this patient. She will need to do contraction with each diet, with breakfast, dinner, lunch, and dinner. So 3 times per day. How many contraction per one time? 8 contraction. Until when? 3 months. Don't forget. Pelvic floor exercise 3 months. Bladder diary 6 weeks. Don't be confused. Okay. So pelvic floor exercise, it will be at least 3 months. We tell it will be 3 times per day. 8 contraction. It should be supervised by a physiotherapist. So it will, if it is beneficial, patient she tell I have improvement, so she can continue in the pelvic floor exercise. One question, Dr. Hassan.
نعم.
Dr. Hassan.
Yes.
Okay. Dr. Hassan, I just now tell you the patient with incontinence, she will have pelvic floor exercise for how much duration?
3 months.
3 months. Okay. So if you have a case of prolapse type 1 or type 2, how much duration pelvic floor exercise?
6 weeks.
No use.
6 weeks. Just a minute. I was writing bladder training. This is 6 weeks. Bladder diary, the investigation is 3 days. Clear? Bladder diary is 3 days. The investigation is 3 days, but the treatment will be long, 6 weeks. Bladder training. Okay, sorry, maybe I am telling something not clear. Bladder diary is 3 days.
It was bladder diary.
Really? Sorry.
Yeah.
Bladder diary. Sorry. Bladder diary investigation is 3 days. Sorry. Bladder training 6 weeks. Okay. Okay. Clear? Sorry. Confused now or clear? Clear? Okay. First, I mentioned this point again. Pelvic floor exercise for urinary incontinence will be for 3 months. For prolapse, it will be 4 months. I just put it beside each others because this is really important information. In the NICE guideline, they mentioned for the patient with urinary incontinence should be at least 3 months. But when he talking about the patient with prolapse, they make it 16 weeks. So 16 weeks, it's mean about 4 months. So 3 months for the incontinence, 4 months for the prolapse. Clear? I just put it with each other so you can remember, because some they are thinking pelvic floor exercise, it's only for 3 months. It's for 3 months and you can continue for the patient if there is improvement. This not means that the patient she will try 3 months and stop. No, she can continue, but at least we talk about at least. But for the prolapse, at least 4 months. Just I put it with here just to remember it easily if it appear in the exam, because anyone will see pelvic floor exercise, you will tell, okay, so this will be 3 months. No, 3 months is at least for incontinence. 4 months is at least for prolapse. Okay, next.
For bladder training, this means for patient to hold urine, you mean, or what? I cannot understand this point. Hold urine and
yes, bladder brother diary. When the patient come in the clinic, you give her you tell her this is a table. You can write every time every day how many fluids you are taking, how much urine you pass, if there is any leak, if there is any urgency. This is 3 days, and she will come back. Brother training, you will tell her this is a treatment. She will try training for 6 weeks. I just mentioned how she will train herself. She tell you, I will go to the bathroom every 30 minutes. You will tell her, try to hold yourself for 5 minutes. She will try for 1 week. Next week, she will increase for 10 minutes. After this increase, until she can hold herself for 3 to 4 hours. So bladder diary is investigation. Bladder training is a treatment. Clear? Clear?
Yes,
Clear
yes,
or
thank
not?
you.
Okay, we can. You can take this one also, Dr. Hassan.
Okay. Patient with genuine stress urinary incontinence tried pelvic floor exercise, not effective. What next treatment?
Yes.
D.
Deoxybutynin. This is treatment for overactive bladder. This is anticholinergic. The idea from oxybutynin, we want the bladder to relax, but here's the patient problem in the muscles around her urethra, weak. So this is not working.
C.
Patient, what?
Duloxetine.
Okay. Bladder stress incontinence. Stress incontinence is the first line treatment until conservative measures. Conservative measure. TVT. This is all the operation. This is restricted now. They do much restriction regarding mesh. So TVT now is the first operation Birch, colbo suspension. So again, stress incontinence is the first line treatment will be conservative measures. What we telling is stop smoking, decreasing her weight, lifestyle modification. Second line treatment, pelvic floor exercise. We tell at least for 3 months. We tell every day 3 times per day, every time 8 contraction. If not working, so the next treatment will be surgical. No drugs. In the stress incontinence, no drugs. Immediately you will go for the surgery. Before, in the old, they do TOT and TVT. Now there is restriction because this operation they are using mesh. And because the complication happen from mesh, now there is restriction. Now in National Health Service, there is restriction regarding mesh. So the first operation will be Birch, colbo suspension. So colbo suspension will be the first surgical treatment for stress incontinence. In stress incontinence, pure patient, she tell you, I don't have any I have stress incontinence, and this is confirmed. If the patient don't have any other symptoms, no need to confirm by urodynamic. You can start immediately surgical treatment. Be careful. No need for urodynamics. If the patient has pure stress incontinence, so after the treatment, the conservative measures, pelvic floor exercise, you can do colbo suspension. What is the treatment for surgical treatment for stress incontinence? Forget TVT, forget TOT. There is restriction regarding mesh. Colbo suspension, as in the picture, either they can do open or laparoscopy. They will tie around the bladder neck and will tie behind the pubic symphysis here, and this is will cause strength of this area, so the patient will not have leak. Sometimes they can do autologous rectus fascial sling. They will cut a small cut in the patient abdomen, and they will take a part from the rectus sheath, and they will do like a sling around the bladder neck, and they will tie behind the symphysis pubis. So like a sling. This is also can hold the urethra, so the patient was coughing. This is will help the patient to not leak during the cough. So what is the surgical operation? Birch, colbo suspension, either laparoscopic or open. The second operation, autologous rectus fascial sling. There is now restriction regarding vaginal mesh in National Health Service. They are providing only if there is no any other alternative for the patient. So there is restriction regarding mesh. So the TVT, TOT, this was all. There is now restriction regarding use vaginal mesh because this is because of possible complication. We can take another one.
Patient with
Yes,
open or
Dr. Gada.
Can I
Madam,
Sure, if there is open or laparoscopic, laparoscopic will be less invasive. But usually they will not give both. Usually they will bring the TVT, TOT, because some they are thinking this is used treatment. So the first treatment will be BERSH. It's difficult to bring, but if there is two options, I will choose the laparoscopic.
when do we use duloxetine? When we use duloxetine?
Okay, still we will talk. Still, don't worry, it's coming. Any other wanted to share? Anyone want to share?
I'll volunteer, ma'am.
I can share.
Dr. Sumaya. Okay, Dr. Sumaya. Yes, Dr. Sumaya.
Question number 29. Patient with confirmed SUI, who is not keen to surgery. This is the answer for para-urethral bulking agent.
Yes, she don't want surgery, so we tell now we have BERSH and the other one, sling operation, so you can do para-urethral bulking agent. This can be done just injection. I will show the picture how they will do. They just will inject around the urethra of the patient, the bladder neck here. Just as you will inject the bulking agent. If you look, it's closed. There is defect here. So when they inject the bulking agent, will not be any defect, and this will help the patient for controlling her urine when she is coughing. Okay. Next. The last option for the patient, there is artificial urinary incontinence. If all the previous treatment failed with the patient, so artificial sphincter can be inserted for this patient as a last option for stress incontinence. So again, what is the treatment for the patient with stress incontinence? Lifestyle modification, supervised pelvic floor exercise, surgery, colpo suspension, either open or laparoscopy, autogenous rectus special sling, intramural bulking agent, artificial urinary sphincter. In the end, if the patient tell you, I don't want any intervention at all, either surgery or others, so you will use duloxetine. Okay, this is just the summary of the treatment of stress incontinence. If he give you a scenario about mixed incontinence, you will tell, ask the patient which one will be the predominant symptoms. She will tell you the urgency, doctor. So I will give her conservative measures, pelvic floor exercise, bladder diary, and if it is failed, I will treat the predominant symptoms. So the predominant symptoms what? So it will be urgency. So I will give her anticholinergic. Suppose this patient, her predominant symptoms, stress incontinence. So I give her conservative measures. I give her pelvic floor exercise and the bladder training, and still not working with the patient. So here, the patient, we tell the first treatment for the stress incontinence, if failed the pelvic floor exercise, will be the surgery. Here, no. If the mixed incontinence, the main symptoms, stress incontinence, after conservative measures and the pelvic floor exercise and the bladder retraining and failed, so it's better to avoid the surgery as a first-line treatment. So I can try anticholinergic. So you get the idea? Yes, it's mixed incontinence. I will treat the predominant symptoms, correct. So in anticholinergic drugs, as a predominant symptoms, the overactive bladder, I can start. But for the stress incontinence, if it is predominant symptoms, so it's better to avoid the surgery first. So maybe the overactive bladder is not the predominant symptoms here. So it's better to avoid the surgery for the patient and give her treatment anticholinergic. Clear this point or no?
Yes, Dr. Gada, I have one question here. If a patient is having mixed urinary incontinence, does she need a urodynamic study before starting any pharmacological treatment?
Stress incontinence?
No.
Stress incontinence?
No, I mean if the patient has come with mixed urinary incontinence,
yes,
and
yes.
we have given conservative measures.
Yes, I tell before in the start of the session, urodynamics will be done for mixed incontinence if the urgency is the predominant symptoms or the incontinence is unclear. I put it in the
Okay.
start of the session. No problem.
Thank you.
No problem.
Thank you so much.
Just repeat.
Thank you.
Just repeat. It will be easy. Who is the next? Who will share? Who will share? Who is with us now? I think Doctor. Who takes the last question?
Hello, this is Dr.
Sumaya.
Tania.
Dr. Sumaya. Please, Dr. Sumaya. Where is Dr. Sumaya? She tell I'm sharing. She is here or no? Okay. Anyone?
She left,
Any
ma'am.
other? Okay. Any other?
Yes.
Ma'am,
One
I
to
can
share?
volunteer. I can
Anyone?
volunteer. I
Yes,
can
ma'am.
volunteer, ma'am.
You didn't share, Dr.
65.
Ankita?
Yes, ma'am.
Okay.
65 years
Go.
old, complaining of stress incontinence. She has tried physiotherapy and pelvic floor exercise, but of no benefit. You advise her for surgical management, but the patient refused. She asked you if there is any medication available for her case. What is your management? Yes, ma'am. I'll go with duloxetine.
Yes, she don't want surgery. She want treatment. So this is not a first line, but the patient don't. She want. So her right. So if you tell her this is according to NICE guideline, it's not the first line treatment. No problem. But my choice, I want this treatment. The patient in the end don't think that this guideline, this is must be done for the patient. No, you will kill the patient. But in the end, the patient she has the choice to choose a treatment for herself. Okay, just I bring the urethral diverticulum because this is very important topic, can appear in part 2 and in part 3. Urethral diverticulum, just in simple way, will be a pouch here. This is the urethra of the patient. This is the bladder. This will be a sac by opening in the urethra. Sometimes with the recurrent infection, this sac can be enlarged and the patient will come with bulging in the vagina, like in this picture. She will tell you, doctor, I have bulge in the vagina.
The slide is not the same. Sorry, Dr.
What?
Radha, the question is in the slide. The slide is not showing urethral diverticulum.
No, still, I'm giving introduction. Just a minute, okay? So it's a patient, she can come and tell you, I have bulge. So what is this? This is a patient, she has a pouch come from the urethra, okay? And this one with the recurrent infection can enlarge, and the patient, she will complain of a mass bulge from the anterior vaginal wall. It can be reached to up to 4 centimeter. From small, very small, up to 4 centimeter, patient can complaining of bulging. When it will be appear more than 2 centimeter, usually she will feel, or even 1 centimeter. You can take the next one.
Yes, ma'am. What is the historical classical triad presentation of urethral diverticulum, I guess? Frequency, urgency, incontinence, no. Dysuria, dribbling, dystonia, yes. Yes, ma'am. It should be B.
So, D,
ma'am. Yes, ma'am, B.
Dysuria, dripping of urine. She will tell you, doctor, I have dysuria. After I evacuate my urine, there is dripping. There is dyspareunia. But this classically, usually it will be seen in minority of the patient. She can have other complaint like urinary tract infection. She can have pain. She can have mass. She can have hematuria, urine discharge, or even retention. This is differential diagnosis because this will be diverticulum. So maybe there is other differential diagnosis. Why? Maybe there is a vaginal wall cyst. Maybe there is cystocele. Maybe there is a urethral crancle. So this is you should do differential diagnosis of the urethral diverticulum before you confirm the diagnosis. Okay, next.
Urethroscopy used for diagnosis of diverticulum should be 0 degree. 0 degree, ma'am. B.
0 degree, because you want to see something in front you. In 0 degree, you are seeing in front you. This is 30 degree if you wanted to see something down here, 45. So 0 degree. Sometimes when you are going by 0 degree, because the defect, because of the infection, this defect can be closed. So it can be closed by about 70% because of the infection. It can be also, there is concomitant, because there is very few, I think 4% could be also concomitant with cancer. I think 4%. If I am not wrong, I think it's 4%. Investigation. What is the investigation of the urethral diverticulum? Urethroscopy, urodynamics. We will tell how much percent of the patient to not answer the question. MRI, ultrasound, CT, micturition cystogram, double balloon urethrogram. Next.
How much percentage of the urethral diverticulum will have incontinence? 10%, 30%, 60%. I'm not sure about the question of the answer, ma'am, but I'll go with B, 30%.
It's 60%. 60% of the patients they will have incontinence. 60%.
Okay.
Ma'am, again,
Valid
what is the
percentage then.
answer? What was the answer for symptoms of diverticulum?
DDD, dysuria, dripping, dyspareunia, dripping of urine post micturition. DDD.
Okay, thank you.
Dr.
The gold
Radha,
standard.
Other question.
Dr.
Let's finish first.
Radha, Dr. Usman here. I just want to tell you, we'll not forget your voice ever. In the exam, if you get a diverticulum, we'll remember DDD.
And remember also in OSCE exam.
I know. You have a wonderful voice, and we will never forget what you say.
If in the exam, in OSCE exam, you see one patient with vaginal anterior mass, ask her about the 3D, dysuria, dyspareunia, dripping of urine post micturition. Don't forget this information. Okay, next. Thank you, Dr. Osman.
Yes, ma'am. The gold standard investigations for urethral diverticulum is urethroscopy, video urodynamics, magnetic resonance imaging, ultrasound, and double balloon urethrogram. Ma'am, I'll go with A, urethroscopy.
No, the golden standard is double balloon urethrogram. This is other investigation. This is from your side, Dr. Ankita. This is noise from your side. You have someone beside you. If
Sorry,
possible,
ma'am.
you close your mic. No problem. You close your mic because also I have much noise beside me. So the double balloon urethrogram, this is the golden standard. There is other investigation we tell before. Abdominal ultrasound, usually you can see the diverticulum. If the diverticulum more than 2 centimeters, if less than 2 centimeters, usually you need transvaginal ultrasound. What is the treatment? If the patient have just minor symptoms or no symptoms, you can start by conservative measures like antibiotic, analgesia. Surgery only indicated if it is increasing or persistent symptoms. Remember that the diverticulum, we are not the one to treat diverticulum surgical. It will be by urologist or a gynecologist who is interested in the urology. The treatment will be removing of this pouch. This will be either by endoscopic or transurethral incision, marsupialization, or diverticulectomy. And this will have side effects like also can have fistula after treatment. This was the last. I think when you study, you should enjoy what you are studying, what you are reading. If you are enjoying, if you are just this is just something I need to study for the exam, maybe you will find it difficult. But if you are try to enjoy what you are reading, this will be more helpful. It can be difficult for the first time. If this is the first lecture you hear about urogynecology, you will not like urogynecology at all. This is my opinion. But if you just try again to listen it maybe 2 times, you'll find urogynecology is very easy. Remember, don't go deep in the informations. If you look to the NICE guideline, it looks only main informations. You are not a urologist doctor. Just you need to know what is the main points you should know. Just if you put for yourself rules, like this is a patient with urinary problems, so the first treatment is urine analysis, not urodynamics. You should know when you should do urodynamics for the patient. Remember, stress incontinence, no need to do urodynamics for the patient. You can treat the patient, no problem, except you do surgery for her and fail. At this point, you can do urodynamics. Remember that the first initial investigation, it will be also bladder diary. You give the patient 3 days. Remember to start by conservative measures, a lifestyle modification, bladder training. Remember after this medical treatment. Remember, if the patient have mixed incontinence, you need to ask what is the predominant symptoms you need to treat the patient. And if the patient she has mixed incontinence and the predominant symptoms urgency, no problem. You can start the conservative measure and anticholinergic. But if the stress incontinence is the predominant symptoms, yes, you will start the conservative measures, and if failed, not go for the surgery first. Start anticholinergic drugs. I wish it. I know it's still 2.5 hours. I don't know what I will do. Every time I will tell I will not pass 2 hours, but no value. Please, if possible, you can post the question in the recall group or Ghada Badran group in Facebook, so we don't want to prolong the session more, especially for who will listen to the record. Okay.
Sorry, ma'am. Just one thing. Just one
Okay.
thing. When do we say nocturia and when do we say increased daytime frequency? Is there any number for that?
Yes, at night should not the patient awake more than 1 time per day. So if anyone awake 1 time, no problem. You are still normal. If 2 times, there is something abnormal. For the day, I think more than 8 times per day, it will be abnormal. But let me confirm this information. But more than 8 per day, it will be abnormal.
Okay.
Yes, ma'am.
Thank you.
More than 8 is abnormal. It's true.
No,
More
no.
than 8.
Night is definitely okay, Dr. Radha. Night is more than 1.
Ma'am, daytime is also okay. It's more than 8 in day.
Hello.
It's true. It's right, ma'am.
It was an excellent lecture, Dr. Radha. Thank you very much. Shukran Kathiran.
Doctor,
Thank you,
just
Dr.
one
Mohammed.
question, please.
Dr. Agata, what is the
Doctor-
next? What is the next lecture for you, and what is the time? How we will know?
I suggest if we can, I will give you the most, because time short, I can give you the most important points in every task, especially herpes, chickenpox, some points in the consent. So I can do mixed lectures, so you can have the main important points, especially you have, I think, the exam in the end. So let me decide.
Where you are putting, where you are posting it, ya Dr.
I
Agata? Where you
will
are?
post in the recall group, Ghada Badran Facebook group. Try to follow the previous sessions. I finished 4. This is the 5th one. Don't miss any session from
Ghada
the
Badran. What is name, Dictora, for the face?
Ghada
Ghada Badran.
MRCOG part 2, Ghada Badran Facebook group, in the Facebook group, and recall group in the Telegram. Or also there is one Telegram group, Ghada Badran, also in Telegram group. There will be organization of crash course with unique monitors for part 2. Don't miss that. There will be famous monitors also in the course. I will post the dates. They are volunteer to give lectures for all the MRCOG part 2 candidates all over the world. They share very excellent session. Don't miss any one of it. I will post the time of the session, inshallah, soon in the Facebook and Telegram group.
Thank you.
Okay.
Hello.
Thank you for
Thank
all.
Ma'am,
Yes,
ma'am,
doctor.
please, one question, ma'am, please.
Yes, doctor.
Hello.
Yes, doctor.
Yeah.
Who?
Multiple. I'm Madhu, ma'am. Dr. Madhu.
Dr. Madhu. Yes, Dr. Madhu.
Yeah. Yeah. In the multiple sclerosis, if given that if she had the recurrent urinary tract infection, is it the CISC only, or is there any option for the suprapubic one?
You mean the patient she will take longer time for intermittent catheterization?
Yes,
you mean
ma'am.
the catheter? You mean the catheter causing for her infection? So you want to pass the point and you want to put for her suprapubic. I am not sure from this answer, but if we better to answer it by evidence from the guideline, it will be better. So if you have evidence about the answer, it will be better. Don't like to answer something without evidence.
No, ma'am. In the February, this 120, one question came, ma'am. In the multiple sclerosis, they gave the scenario that the patient is having the recurrent urinary tract infections, very recurrent urinary tract infection. So I'm confused whether to choose the continuous intermittent catheterization or the suprapubic one.
Okay, so Dr. Madhu, let me, I think there is one talk articles about this topic. Let me confirm the answer I just wrote here in the paper, and I will answer it in the group, and I will post also next time in the session, inshallah. Okay?
Thank you. Thanks a lot.
Thank you, ma'am.
Great session, ma'am.
Thank you so much. Wonderful session. Thank you.
Thank you, Dr. Nikita. Thank you for all of you. I wish you enjoy. Just try again to listen, repeat. Don't worry. If you miss any point, just repeat it again, and it will be easy, inshallah. Thank you so much.
Dr. Radha, may Allah bless you. Really, you have been a great help to all of us.
Thank you, Dr. Ozma. All the best for all of you. Just be serious because now time short. Just be serious.
Yes.
Even you didn't
Yeah.
study, I know some of my friends. Just be serious in the last
Yeah.
time. In the
Pray
last
for
months,
us,
you will
Dr.
run.
Lada. Pray for us. Yeah.
Yes, you will run, and you can also still pass. Thank you a lot for
I
all
just
of you.
feel that whatever you said last time, whatever you have been saying has been coming true.
Thank you for all of you doctors. I don't know who's talking now.
Dr. Uzma, this Dr. Uzma.
Yes, Dr. Ozma, thanks a lot for your feedback and all the best for all of you. Just will continue in the group and the next session time and date, inshallah, I will post. Thank you for all of you and goodbye.